Hello, hello, and welcome to another stream of Advanced Pharmacology. My pages may not line up because mine's a PDF, but we'll be reading it in its entirety. So, if ever I'm going too quickly, please make sure you hit that pause button. Alright, so we'll jump right in. Rational drug selection and prescription writing. So, the responsibility of prescribing. As a practitioner, you will assume great responsibility when caring for patients. The ability to prescribe medications is both a privilege and a burden. Although you may be familiar with many drugs through your previous practice as a registered nurse or other members of the healthcare field, giving medications and prescribing medications are two very different things. There are many different issues to consider when writing a prescription, many of which we discussed in this chapter or in the previous chapter regarding prescriptive authority. The best way to keep your patients and yourself safe is to be prudent and deliberate in your decision making process. Having a documented provider patient relationship with the person for whom you are prescribing. Do not prescribe medications for family or friends or for yourself. Document a thorough history and physical examination in your records. Include any discussions you have with the patient regarding risk factors, side effects, or therapy options. Have a documented plan regarding drug monitoring or titration if applicable. If you consult additional providers, note that you did so. Finally, use the considerations provided in the following box to assist in safely and rationally choosing one medication over another. So, helpful applications on websites for safe prescribing. So, there's always Hippocrates, Lexicomp, Pepid, the Physician's Desk Reference, and Up to Date, as well as the Center for Disease Control and Prevention for Antibiotic Guidelines, Elsevier's Clinical Pharmacology, again Hippocrates, Pepid, and the Prescriber's Letter. So, something to consider is drug selection, the cost. The cost of medications in the United States has risen steeply within the past 10 years. Increasing cost is related to multiple factors, including corporate competition and proactive increases in anticipation of the Affordable Care Act. It is also noted that one of the reasons people do not adhere to their prescribed medication regimen is its excessive cost. Often, we are so concerned with obtaining the right diagnosis and making our patient well that we overlook key pieces of information, including the patient's financial status. When patients cannot afford the drug you prescribe, they may not get well, even though they want to be compliant. It is of critical importance that providers ask patients if they have difficulty obtaining their medications, because it is cost prohibitive. If you find that your patient is having difficulty purchasing the prescribed medications, consider changing pharmacies or drug regimens. The cost of a drug can vary widely between pharmacies, even within the same city. In addition, many corporations have created generic $4 lists of special prescription programs that allow patients to fill their medications for a reasonable cost. In addition, all health plans through the ACA are required to include prescription drug coverage, although these vary greatly. As a prescriber, you need to be familiar with the local resources for medications, assistance, and low-cost medications. So, the guidelines. When in doubt, follow current guidelines for the treatment of a particular disease or symptom. Almost all medical and nursing societies have published guidelines, including the American Heart Association, the American College of Cardiology, the Infectious Disease Society of America, and the American Diabetes Association. It is the provider's responsibility to keep abreast of new recommendations or changes in guidelines and to incorporate these into their prescribing practices. Although closely following the guidelines is desirable, we must always take into account that our patients may not fit well into these guidelines and that individualized care is always best. In these cases, it is important to document the rationale for deviating from standard of care. The availability, therefore, every facility and pharmacy provides drugs according to a selected formulary. This formulary is selected by a panel of pharmacists and providers and may be subject to following guidelines created by regulatory agencies, such as the Center of Medicare and Medicaid Services. The formulary may also depend on regional and national drug supplies, drug costs, and available rebates, and the presence of generic medications on the market. In short, the drug you want may not be available in your facility or at a specific pharmacy. This can affect your choice of medications. Become familiar with the formulary where you are employed and know that it can change over time. Often there are substitutes or similar medications you can order in place of what you originally intended. For example, omeprazole may be indicated for the treatment of erosive esophagitis, but the formulary contains esomeprazole instead. Considering interactions. As noted throughout this text, there are very few medications that do not interact with either another medication or a food. Polypharmacy greatly increases the risk for interactions. Some of these interactions are negligible, but some can have life-threatening consequences. It is of crucial importance to ask the patient about all current drugs, including over-the-counter medications and other herbal preparations. Many patients do not consider over-the-counter or alternative pharmaceuticals as medications and may not mention them unless you ask specifically. When adding a new medication to a patient's regimen, check for significant interactions. There are many resources that allow checks for interactions between multiple medications or food at one time. If there is a low-risk interaction identified, you may find it acceptable to discuss this with your patient, document the conversation, and then prescribe the medication. If there is a relative or absolute contraindication to the proposed drug combination, it is best to choose an alternative, if at all possible. Considering side effects. All drugs have side effects. Some are adverse and some may be beneficial. In addition, one patient may experience adverse effects to a medication whereas another patient may not. It is important to note the pertinent side effects for each medication and to ask a patient about presence of symptoms after initiating, stopping, or changing a medication dose. When assessing the risk to benefit ratio of a medication, one must consider the severity of the side effect. If a patient started on a new antihypertensive medication, has a decreased blood pressure, and therefore improvement in hypertension, but experiences fainting, a decrease in dose or a different medication should be considered. Allergies. At times, guidelines may suggest a particular drug for a specific ailment. Unfortunately, your patient may have an allergy to that medication or class of drug. It is of critical importance to determine the type of reaction and to document in the patient's chart. Then select an appropriate drug. May begin. In the case of severe allergy, such as anaphylaxis or swelling of the face, these drugs are absolutely contraindicated. But in the case of a patient who experiences vomiting or other similar reactions, the drug may be used again if necessary. The desired choice would be to use an alternative medication that is just as effective. For example, a patient with pyelonephritis who is allergic to penicillin can benefit from fluoroquinolone instead. Liver and renal function considerations. Many drugs are metabolized and eliminated by the liver and kidneys. If these systems are impaired, this can lead to increased adverse effects and possible medication overdose. Frequently, drugs have special decreased doses or different dosing schedules for patients with hepatic or renal impairment. This is known as hepatic dosing or renal dosing. Despite known safety or decreasing doses in some drugs, If there is a different option available, it is prudent to choose a different medication. For example, morphine sulfate is highly metabolized by the kidneys. For patients with renal impairment, morphine can be used to treat pain, but the better choice would be fentanyl because fentanyl does not require dose reduction in patients with renal impairment. Although some drugs are safe to give or can be used with caution in patients with hepatic or renal dysfunction, other drugs are contraindicated in these patients and must be avoided at all costs. The need for monitoring. Some drugs require frequent monitoring at initiation or throughout the duration of treatment. Some examples of these medications include warfarin, lithium, opioids, and immunosuppressive therapies, so your tacrolimus or sirolimus. When levels of these drugs are not within therapeutic range, serious patient harm can occur. If a patient does not have the ability to attend frequent laboratory appointments, cannot take their medications reliably, or is not easily reachable by phone or electronically, it may be best to try and avoid these medications if possible. Special populations. Populations that deserve special mention when thinking about medications include the pregnant or nursing mother, pediatrics, and the older adult. These populations are addressed in depth in Unit 3, Drug Therapy Across the Lifespan. In addition, lifespan tables are present in many of the chapters throughout the text to alert you to special considerations. So, prescriptions, the necessities. When writing any prescription, there are key elements that must be present to compare a complete prescription. An example of a common template for a written prescription is provided in Figure 2.1. These elements include the prescriber's name, the license number, and contact information. Prescriber U.S. Drug Enforcement Administration, the DEA number, if applicable. Patient name and date of birth. Patient allergies, the name of the medication. Indication of medication. Medication strength. Dose of medication and frequency. The number of tablets or capsules to dispense, and a number of refills. If you're using an electronic medical record to complete prescriptions, many of these elements will be mandatory for the provider, although many will already be completed by the EMR, including the prescriber's name and contact information. It is important to note the indication for the medication because many drugs are used for more than one purpose. This allows for the patient as well as for the provider to understand your intent for prescribing this particular drug. So here's that example. So types of prescriptions. Via the telephone. A common and convenient way to create a new prescription or prescription refill is by telephone. A prescription can be called into a pharmacy by you or a specific designee. This is often done by leaving a message with the correct information, although this is a different way of prescribing. The necessities remain the same. Certain medications cannot be prescribed or refilled by phone. These include medications within the Schedule II category. Patients must have a written prescription for these medications. The only exception to this rule is during an emergency. In this case, a telephone order can be used for a limited amount of medication, but a written prescription must be presented to the pharmacy within 7 days. Which brings us to the written prescription. Providers have been writing prescriptions in the United States since the 1700s. Patients even received scripts during Prohibition in the 1920s to purchase alcohol for medicinal use. Interestingly enough, these paper scripts did not look much different than they do today. This is because the required elements for a complete prescription have not changed over the years. Although healthcare is making the transition to electronic prescriptions, many providers still use written scripts to prescribe medications. Written prescriptions, like telephone calls or electronic scripts, contain all the necessary elements as described earlier in this chapter, although all the correct prompts for information may be pre-populated on your script. there are still some important points to consider. If you use a script with a different provider name or a generic script, make sure your name and contact information are printed legibly on the paper. Write all prescriptions in ink or indelible pencil. Avoid abbreviations such as U for units, MSO4 for morphine, or QD for daily, because these can increase errors and therefore no longer acceptable. For a list of all the abbreviations to avoid, look at Table 2.1. And here is that said table. So I'll leave that up for you to take a look at. Again, as always, hit pause if I'm ever going too quickly. In addition, never write prescriptions on a pre-signed scripts or pre-signed blank scripts for other providers or staff. Although this may seem like a convenient way to ensure availability to patients at all times, it is ultimately an unsafe practice. Finally, many facilities provide tamper-resistant scripts, or some states require their use, especially in the prevention of substance misuse and abuse. A few tamper-resistant security features include hidden message technology, which appears when the script is copied on a copy machine, anti-copy coin rub, which appears when rubbed with a coin, and distinctive security backgrounds. To learn more about these features, you can always take a look at the following website, and I'll leave that up for just a moment. E-prescribing. With the advent of the EMR, many pharmacies now have capabilities to accept electronic prescriptions. In fact, CMS provides incentives for using an EMR to prescribe medications. This program, called Meaningful Use, is thought to contribute to increased patient safety and improved patient outcomes. Using an EMR allows provider to select a specific patient-selected pharmacy. After the correct medication information is entered, the prescription is automatically sent to the selected pharmacy. This is beneficial because there is direct transmission of information, making error less likely. Also, the prescription can be ready for the patient when the patient leaves the facility. The patient does not need to drop off a paper prescription and then wait for a medication fill. Limitations to e-prescribing include scheduled medications which still require a prescription on tamper-resistant paper. In addition, many healthcare organizations still do not have a functional EMR, and many pharmacies still do not have the software capabilities to process these requests. In these cases, paper prescriptions are still necessary. Your refills. There are a few things to consider when refilling a prescription. Questions you should ask yourself include the following. Is this a newer medication for the patient? Am I changing a dose or frequency of the medication? Am I adding new medication to their regimen? Is the patient having undesired side effects? When do I expect to follow up with this patient? If the patient is requesting a refill by phone, when was the last time I saw this patient? Do I need to see the patient again before this refill? Is this a Schedule II medication? If the answer to any of these questions is yes, consider a shorter time between refills, 1 to 3 months. The exception to this question is with Schedule II medications. There is not eligible for refills and must have a new prescription each renewal period. When changing or adding to current medication regimens, it is prudent to follow up with the patient by phone or in person to assess changes. This time can be used to discuss new or increased side effects, check vital signs, obtain laboratory work, or make further adjustments. When a medication such as warfarin requires frequent monitoring with drug levels, an even shorter refill allotment is reasonable. If the patient has been maintained on a current dose of a medication for some time and remains stable, it is likely acceptable to continue to refill that medication for a longer time period. Assistance. Applications for tablets and phones. This textbook will be paramount in your learning, but it may not be convenient to carry around in the clinical setting. Although we encourage you to use this textbook to the fullest extent, there are many new applications and websites available to assist providers with safe prescribing. It must be noted, however, that all these tools still require common sense and good judgment on the part of the prescriber. As stated previously, one must take into account the individual patient as well as multiple other factors, including cost, side effects, and medication formularies. An application can assist you with the basic suggestions in dosing and duration, but ultimately, there is no substitute for sound practice. Collaboration. As reflected in this chapter, writing a prescription safely can be complicated. It is strongly encouraged that you use all available resources, including your colleagues. Developing a relationship with your pharmacist can be one of the most helpful and fruitful relationships you cultivate, because this is their specialty. Pharmacists will likely have additional information on formulary and drug interactions, as well as suggestions for adequate medication dosing. In some practices, pharmacists are responsible for medication initiation and titration based on standardized protocols. Infectious disease specialists can also be a very helpful resource. Choosing an appropriate antimicrobial agent for a specific infectious process is often difficult for a new practitioner. A local infectious disease specialist can provide guidance on resistance patterns, common local microbial flora, and correct doses, as well as on duration of treatment for specific infections.